Learning Session 4 webinars. We had one last week, and we're going to close out with the one today with the remaining practices and participants. So welcome to everyone on the call today. We've got a lot to cover, so I'm going to go ahead and move forward here. You all are very familiar with the webinar etiquette. We actually are going to have everyone on mute, with the exception of the presenters today. So if you have questions or any information that you need technical support, go ahead and write that through the chat box, and Ed Wise will be monitoring that. So just to anchor us all in terms of where we've been over the last year, we're going to go kind of back to the very start here, and we're going to begin with our project aims. And as you remember from all of our sessions, we've always talked about the two aims, and one, of course, the CQN stands for Chapter Quality Network, in which our aim was to build a sustainable infrastructure within each of the practices to achieve measurable improvements in ADHD care processes. And the specific aim was between the time of January 2016 and really for most of you all through December, even into January, you will be achieving measurable improvements in care processes by implementing these key interventions. And so that's what our work has been over the last year. So let's go back and look at how we measured success. And you all are familiar with all these. I'm not going to go over these with you because this is what we review with you every month and in our learning sessions. This was a measure set that was developed by the national team with the input from the chapter leaders and certainly all of the evidence and past projects. Oh, sorry about that. I have my arrow on here. Let me go back here. So we will be getting to the specifics of that in just a second here. This is a diagram that you should be familiar with, and of course where we are today is Learning Session 4. The end of our formal journey in terms of our formal learning network, although we are confident that you all will continue to focus on standardizing, delegating, and building reliable systems. And in fact, in many of the chapters, there's the intent of continuing over the next few months. So just very briefly, again, this is just by way of kind of remembering all of the progress that we've made. We focused on different types of interventions in different action periods, and as you remember here, we had 3 action periods. So action period 1 was really getting started, getting going with the QI team, beginning to implement PDSA cycles, and of course a lot of the work was on testing ways to just really start using the MeHealth registry, and for many of you all that took a good chunk of time to get that going. In action period 2, we focused on the Vanderbilt returns. We increased the focus on the parent partnerships to engage teachers in schools, and we'll talk a little bit more about parent and teacher engagement later in the program. And then we started some deep dive into what we call deep dive into the medication management, and we have another of those in today's session. And then more recently, we've been really focusing on sustainability. How are you going to continue this with or without the registry? The importance of having population-based registries that can provide tracking and monitoring and measurement of the particular area of focus, and that's a critical part of sustaining the work. And then making sure your workflows, your standing orders, your protocols, everything's hardwired to continue this fantastic work that you've been doing over the last year. And then continued emphasis on medication management. In particular, we've been focusing, as you know, on the 50% of those children that have comorbidities as well, and we will touch on that again today. So here's where we're going. Here are our objectives for today: to develop more expertise in ADHD medication management, and again, focusing on comorbid conditions, including basic treatment principles with Dr. Wiley. And then we have Dr. Berman, who will introduce to you in a few minutes, that will describe the new payer environment. We thought this was important to kind of take that population health discussion that we had with you all on our monthly practice calls, kind of really more introducing the concepts of population and now applying that to the payer environment, at least as we know it today. And then we're going to wrap up with describing describing some of what the national team described as some of the key successes, and I know the chapters will certainly be following up with you all as well with the key successes and learnings. And then just a brief outline of project wrap-up, things to consider. So today's presenters. So as I mentioned, Dr. Wiley and Suzanne Berman, who is part of our AAP section on administration practice management, will do the payer environment, and I will be doing the final celebrating our successes and kind of the next steps. So our agenda real quick. Here we go. All right, so we're going to test the polling capability here as we move into the medication management. What's your favorite color? And go ahead and pop one of the answers on the slide and submit. And let's see what we have here. And I just think it's hilarious that the favorite color is not the same as the bars, but you get the idea here that we've got, people that are able, all we have to do is just respond to the slide as Dr. Wiley gives you the options during the case studies, and we can look and see what people have responded. So with that, I'm going to go ahead and turn it over to Jay Wiley. You may need to unmute, Dr. Wiley.
Sorry, can everybody hear me?
I can hear you.
Okay, great. All right. Well, we are going to get started and go pretty quickly because we realized last week that we have a lot of information that we want to go through. So I don't have any relevant disclosures to make. And then a couple of housekeeping things. Please type your questions into the question box. We'll try to get as many of those in as we can, but last week I'm afraid we had to answer those by email. But don't hesitate to ask questions if those come up. Our learning objectives, we're going to spend most of our time developing more expertise in medication management with the goal of really driving toward optimizing medication effect. And we're going to also take a look at comorbid conditions and spend a few minutes talking about basic treatment principles for those. Before we did that, there was some questions about complementary and alternative medicine for ADHD. And basically, there's been a good review of this. A lot of studies have been done and not really found significant benefit anywhere near the effect size of stimulant medication to CAM practices. There are a lot of things out there that our patients bring in terms of supplements and other things that have the words focus or attention on them. And I always just tell patients that those have not been evaluated by the FDA. We can't even tell them what's in those little pills. And also there are lots of other things that have been offered. I always say everything from meditation to medication has been offered for ADHD. And for the most part, there's very little evidence that they're effective. And they can be quite expensive. So having said that, of course, a good night's sleep is important, and in today's world, electronics have to be turned off. Good nutrition is really critical, and adding omega-3 has been, the studies are sort of divided about omega-3 fatty acids, but there's some studies that suggest that high-quality omega-3 products can improve focus, and so why not add that because it's healthy anyway. And then, of course, there are a few divided studies on limiting food additives and preservatives, particularly helping more with hyperactivity in very young children. But the studies are not well blinded, so it's hard to make a recommendation. On the other hand, it doesn't hurt anybody to eat a little closer to the earth and avoid preservatives and additives for a short time to see if it makes a difference. We definitely think that kids need to have downtime, free time, and advocate. We always advocate for our patients to have recess and exercise in PE and, of course, at home. So those things are all helpful for everyone. But they don't have the effect size of stimulants. stimulants have an effect size of 1.0. Nothing else really comes close, including the non-stimulants, which have roughly half of that effect size. And that's why stimulants are the treatment of choice as a general rule when medication is used. So we're going to start our case studies, and we'll begin with a 9-year-old, Robert, who's first grade teacher felt he was hyperactive, had a few behavior problems. He repeated the second grade due to immaturity, but it did much better the second time around. His reading and math were both on grade level. And now he comes to you in the third grade, struggling academically, and is being teased by the other kids because the teacher has had him sitting at a table or a desk by himself. This seems to have spilled over into his confidence, and now he wants to quit soccer, but his mood is otherwise normal. Mom reports the homework is a nightmare, and he has some worries that he's going to fail again in third grade, and he worries about the fact that he failed second grade, but he's otherwise not anxious. And then you can see his Vanderbilt assessments there. So the first question is, does Robert meet the DSM-5 criteria for ADHD before we get started? So I'll let you all poll there. All right, so let's look at our results. And I definitely agree that he meets the DSM-5 for the criteria. The number of symptoms occurring are in the right range. He started significantly before the age of 12, which is criterion B. Symptoms occur both at home and at school, and he's definitely had impairment with a failed grade. And really, we looked at anxiety and mood, we looked at sleep, and we also considered that his academics, that his math and reading were on grade level. So we can feel pretty confident that criterion E, not better explained by something else, has been met. So after discussing the benefits and risk of stimulant medication, the first question that the parents want to know is, could we please start a non-stimulant? And so here are some choices for your response. Get adamoxetine out of the cabinet and explain the titration. Explain that stimulants are more effective. Ask if they still have safety concerns about stimulants and address those. And then consider Intuniv, which is FDA approved for monotherapy, and start with 1 milligram. So we'll let everybody vote there. Okay, great. A couple more. All right. So this is great work on your part, and we would say probably that both B and C, the ones that you all answered, are true. So y'all did a great job. Stimulants are much more effective, as we mentioned earlier, but then the chronic care model reminds us to be collaborative in our decision making and going back around and asking what were the concerns about stimulants in the first place. There's still such a stigma and so many safety concerns despite years of safety data, and we thought, of course, non-stimulants, when Strattera came out, we thought Strattera was going to be the end of ADHD as we knew it because it wasn't a stimulant, but it has just as many side effects and less effect size. So they trust you and are reassured, and so they're ready to proceed with a trial of stimulant medication. And so our third question is, well, where? What do you want to use? And A is 36 milligrams. A new medication your pharma rep was telling you about last week. Maybe start with 30 milligrams of Vyvanse, or try any stimulant at low dose with instructions for dose titration and a plan for reassessing effectiveness and side effects in the first few weeks. And so you all can vote. All right. So we had a couple of folks go with sort of medium doses of methylphenidate in the Concerta and 30 milligrams of Vyvanse, and nobody went with the drug rep. And 90% of you said any stimulant at low dose. So the guidelines say FDA-approved medicine in this age group, as long as and the recommendation is to go low and titrate to maximum effectiveness. So when we were reviewing these with a couple of the other content advisors, we laughed about B because the answer could very well be B, and for this reason, sometimes they can try some of those branded products at no cost, and that can be a win-win for the parent. So we know that insurance decides what medicine we prescribe sometimes. I mean, it depends on the patient's plan, and while we would like to be the ones deciding, very often insurances will require trials of certain medicines that are on their formularies. And sometimes the pharmaceutical coupons and those sorts of things can make a med trial more affordable than even a generic. So we do have to consider that, as well as whether the patient can swallow pills. So you started with Concerta 18, but it wasn't on the formulary, so you regrouped and tried Metadate 10, and the patient was a little more tearful in the afternoon, and titrated to 20 milligrams after some time. After initial problems going to sleep, this subsided, and the teacher Vanderbilt improved, but with persistent inattentive symptoms, and a little impairment with the assignment completion, organization, and reading. And the thing that really stood out was that his behavior had improved night and day. The teacher did not notice any side effects on the side effects checklist other than a little bit lower appetite at lunch. Mom is pointing out that homework time is still quite a challenge. Weight was down a bit, but no other side effects or obvious things going on when he was seen back. So what would you suggest here? Let's stay where we are. Let's try Concerta 27, increase the Metadate dose, or switch to Adderall. And the last choice is to add an immediate release methylphenidate for homework time. So if y'all would vote now, lots of choices, and I think there are a number of choices. So. All right. So these answers are pretty evenly divided, and so let's think about continuing the Metadate 20. So those would be, that 9% of you would be the folks that, are not going to titrate to the most effective dose, because clearly there are persistent symptoms and impairment. So we would definitely recommend a change from the Metadate 20. Changing to Concerta 27 gives you both an increase in dose, and in general, Concerta, with its Oros technology, will last longer than Metadate, which is more of a 6 to 8 hour window, whereas Concerta, if you look at the PK data for Concerta, it's more in the 8 to 10 hour range. So that might spill over and help with homework. Going up on the Metadate is another good choice, because if you go up on the dose, you're likely to go out on the duration. So increasing the dose will lead to longer duration of action, and increasing the dose and longer duration of action with the Concerta. We would titrate methylphenidate before switching to the amphetamine class. And then the last one, a lot of folks said, we'll add the medicine for that homework time, but when the symptoms are still persisting and the teacher is still noticing inattentive symptoms as well as performance problems coming from that inattention, we really have to consider going up on the medicine for the first half of the day. So we would likely either recommend going up on the Metadate dose or changing the delivery system of the medication and titrating the dose up slightly to see. Both of those would be good options. So this is the therapeutic window. You know, we use this for all kinds of medicines, and I really like this strategy of talking to patients about medicine. In fact, I tell everybody, I draw this rectangle, you know, all day. And what we want is for the medication to, I hope you can see the cursor, but we want the medicine to come into the U zone, getting out of the ADHD zone and into the U zone, and the x-axis is time, and the y-axis is medication effect. So not enough medication leaves you in the zombie zone, in the ADHD zone. Over medication leaves you in the zombie zone. And somewhere between A and Z is the letter P for perfect, and that should be the U zone. And I frequently tell the kids, you know, we're not trying to change you, we're trying to get rid of this attention problem that has you frustrated. That really seems to resonate, especially with middle schoolers. That's what we want, is the medicine to come in, be just enough effective, and then optimally effective, and then when it wears off, the day is done, and it's good. So I'm hearing that the cursor is not showing up, and unfortunately, oh, I can. Here we go. So this is the U zone. Now can you see that? So sometimes medicine duration is too short, and you can increase the dose and it'll go longer, or sometimes if it's working well enough, you can add that afternoon medicine. So I hope you can see that now with that cursor added. Where we don't want to be is up here, and we don't want to be down here. And again, this axis is time. The x-axis is time, medication effect. So I think we find that drawing this out for our patients really helps them understand where we are. There are 5 Ds of medication optimization: the drug, which molecule, and then what isomers of that drug. How much are we going to give? You know, less is not necessarily better. Tell parents not to worry about the number of milligrams. More may help even less because it can lead to over-medication. So finding that just right dose can be very tricky, but is definitely doable. One of the things that I think we maybe sometimes don't pay attention to enough is the mechanism of delivery. In other words, how is the time-release technology, which one fits best with that patient's unique metabolism of methylphenidate or amphetamine? So it's the time-release technology. Sometimes these kids that are on a medicine and they get very weepy in the afternoon, you know, just changing the time-release technology. It works well in the morning, but it's not working well in the afternoon. And remember that the pharmacokinetic data are pooled in the package insert. So you're going to see what the average is, but those curves are drawn through lots of individual data points. And the individual's metabolism of each of these molecules varies greatly. So now, I always believe patients when they come back and say the Concerta wears off at lunchtime, it's because they're rapid metabolizers. Remember that that has to be individualized, as does the dose. In a separate correspondence, you're going to get PK data slides for all the commonly prescribed stimulants. And if you look at this and then you look at the time when the patient is having symptoms or the time when the medicine's wearing off, you can learn a lot that helps you decide what medicine to use next. The duration of action is affected by the isomer, the dose, and the delivery system. And again, it has to be balanced by the individual's metabolism. The L isomer of amphetamine tends to be longer acting, and the D isomer tends to be more rapidly cleared. So that's why, for example, Adderall might last up to 5 to 6 hours in some kids, immediate release Adderall, because the L isomer, which is not as potent, not as dramatic of an effect, but it does last longer than the dextro isomer of amphetamine. That's why Vyvanse has been such a popular medicine, because it uses a technology to really prolong that dextroamphetamine effect. And then we recommend medicine daily now. You know, for years we recommended medication holidays, and we recommended not being on the medicine on non-school days very often. But what we found is that daily medication tends to attenuate side effects so that they don't recycle the side effects every Monday. And also there's emerging evidence that more regular treatment improves executive function over time. In other words, having the ADHD treated can more regularly leads to improvement in attaining skills and independence. So let's look at another case, this time a 13-year-old Sarah, who was treated for ADHD since she was 7, had been on Concerta 54 for several years when she presents saying it's not working anymore, like she's not taking anything. She had started her period about a year ago and is regular at this point. She has no new health problems. There's no change in her psychosocial history. And she's in the same middle school that she went to 6th grade. She has good friends. Her grades have dropped, and teachers are reporting excessive talking and being a little more disruptive this year for the first time in several years. And she denies being anxious or depressed. So your next move might be to screen for substance abuse, ask about compliance. Is she taking the medicine regularly? Ask if the pill looks different, schedule an evaluation for learning disabilities, or a lot of those, or all of those. So what do y'all think we should do? Or is there one that stands out maybe that okay. So screen for substance use, nobody said that. But remember the AAP guideline is that as we go into the teenage years, and in many communities that starts at 12, substance use can be a problem, and it really derails ADHD care. Compliance is a good one. Middle schoolers are famous for deciding that nothing's wrong with them. They want to be like everybody else, and they begin to cheat their medicine. If you see all of a sudden the medicine just stops working, not taking it is number 1, 2, and 3 on my list. The parents will always say, no, I watch her take the medicine, and I always, have to explain that the kids are more creative than we give them credit for. So that it's good to have an honest conversation with the child about you don't want them on medicine that they don't like, so they don't need to hide that they're not taking their medicine. We want to know if they don't want to take their medicine. And then C is correct also because despite the fact that the FDA has issued guidelines that the non-AB rated Concerta generics, the different delivery system other than the OROS, capital O, capital R, capital O, capital S, technology for delivering methylphenidate, those non-AB rated Concerta generics should not be substituted when we write for Concerta. Even though they're still FDA approved at this point, they shouldn't be substituted for Concerta. So, and they do tend to be less reliable, and their time release is less reliable, and their effectiveness is less reliable. It doesn't mean they didn't work perfectly for some kids, but if a Concerta kid has problems, make sure that the pill looks the same. And then finally, bright kids can cover up their dyslexia and disorder of written expression, which is the number 1 learning disability associated with ADHD. Almost 60% of ADHD kids have some component of disorder of written expression, can definitely manifest in adolescence, especially, like I said, in the smarter kids. So we want to definitely probe the question about compliance without judgment. We want to ask them, what about the medicine don't you like? And I'll even go a step back on that and say, what is it about the diagnosis that you don't like? And very often they'll get tearful and not feel that things are good. Sometimes we forget that as they become adolescent, we need to talk to them more and mom a little less, and involve them in the way they're feeling. Educating the patient is part of the chronic care model, and bringing them up to speed. One of the Georgia content advisors shares a technique that I've found to be very helpful, and that is to have a little PowerPoint with some brain imaging slides, which are available on the internet, that shows sort of some of the newer imaging studies. It makes ADHD real to them. And then, of course, always letting them know we don't want them on medicine that gives them side effects or changes their personality, letting them know that if the medicine changes them instead of just changing the ADHD, we should change the medicine. So she denied substance abuse, and after a thoughtful interview about compliance, she said, no, still taking the medicine. The pill shape didn't change, and you even remembered to ask about sleep and see if that was a problem that was contributing to her symptoms, and she's getting a reasonable amount of sleep for a 13-year-old. And Mom reports that really there's never been any concern about reading or writing, even long sentences and pretty extensive work. So at this point, you feel like you've kind of looked into other things that may be causing this, and we're going to make an adjustment to the medicine. So how would you all come down on changing this? What should we do? And I think that people are weighing in very much in the thought of the folks who sort of got this presentation together. Most of you would say going up to 72 milligrams. So, you know, the conventional wisdom that most of us espouse is titrate, then switch. Or if you remember, well, I won't even say that. So titrate and switch. Make sure that we've sort of run the gambit on the methylphenidate, and at her age, a bump up in medication might be helpful. Changing the isomer, theoretically that could be helpful, but probably just going up on the medicine she's got right now since she's not having side effects. Okay, so the main thing is to avoid the knee-jerk increase in dose or change the medication without considering other factors, but we didn't do that, and so we've since there wasn't another explanation, we changed it, and you bumped her up to 72 milligrams is what you did, and had them call back in 2 weeks, and they report to your nurse, you know, maybe it helped a little, but we just don't see it. Really not doing as much good. She's still struggling, and she seems to be having a little bit more side effect, not sleeping quite as well on 72. So now, you're going to have her do what before she comes back to see you? Are you going to change to 40 of Vyvanse, change to 20, and consider titrating over the first week or so? Change to Adderall, a different amphetamine product, and use the immediate release formulation twice a day. Let her know that 72 milligrams is the maximum dosage of methylphenidate. But maybe add 2 milligrams of Intuniv and do a 2-drug regimen. Which would you think you'd come down on in deciding what medicine to do? All right, perfect. So I would definitely agree with the change to Vyvanse. Any amphetamine really, but in this one, the more reasonable choice is Vyvanse 20. And again, rather than assuming that 40 milligrams is the right thing, it's really best to retitrate. The body, individual patients are affected by these medications differently, and especially within between classes, between the methylphenidate class and between the amphetamine class, you really can't crosswalk your dosages at all or glean anything from the fact that she's a high methylphenidate. She requires high doses of methylphenidate. So I would definitely try 20 milligrams of Vyvanse and titrate. Now, I will say there's a caveat to this one, and that is I wrote the answer the way I do it, which is that I tell them to take 2 of the pills the second week unless they have significant side effects on one pill, and then check in and come back on whichever dose they like better. The AAP guidelines say weekly titration is okay, but both of the other content advisors that reviewed the presentation suggested that they would wait and go up maybe a couple of weeks after trying 20 and only go up by 10 milligrams. So I don't know that either way is right, and it's really up to your discretion as to how quickly you go. The other advisors were concerned that we would overshoot and have side effects, and then my experience is that they get a little frustrated with if the 20 milligrams isn't working, then they tend to call back and say it's not working and that sort of thing. So, and Anne Marie Hain is asking a questions about insurance companies. So what I do is I bring them back so quickly that I just give them 30 pills, and then they come back quickly enough, and they're almost never going to be on the same dose that we did, and we have had to occasionally write a PA to override because we later tell them in retrospect that we titrated. But that's a good question. That would probably be state and payer specific. So 3 weeks later, she comes in and reports that her symptoms are much better on the 40 milligrams, but yet she feels a bit edgy and anxious. I need to be doing something productive all the time, but she didn't really feel that way on 20. She notes that her friends say that she's kind of gotten crabby, and her parents notice that she's more argumentative on 40, but not 20. And she's having a little more trouble falling asleep and a little more appetite suppression than she did on the Concerta. So the next move would be to what? We're either going to maybe titrate down to 30 and split the difference, try a different isomer, maybe 20 milligrams of that, even a different isomer, more of a 50-50-DL, Adderall being the 75-25D to L isomer, VKO 50-50, and ask her to continue the 40 though. Maybe the side effects will just get better over time, and then too many side effects, back to Concerta. So your next move would be all right. So it sounds like y'all really favored going to 30, and I think that we meant for that to be fairly obvious that splitting the difference would be a good idea. It's what the other content advisors would have done as a first line. But I will say that the 4.2% of you who said continue the 40 milligrams and see if the side effects wane. Side effects are inversely proportional to time sometimes, and they will get better over a few weeks. And so that answer I don't think is necessarily incorrect. But I would probably drop it back to 30 to get rid of the side effects if possible, and then titrate back up to 40 at a later date if her effectiveness waned. Remember, most experts estimate that when you have a patient dose optimized, you get them exactly where they need to be, and we'd like to do that early on. We don't want to wait. We want to get that done in the first few weeks to month or so of treatment, month to 2 months of treatment. We want to titrate to that optimal dose. When you get there, it turns out that about 50% of the kids will need an adjustment upward of dose in the first year. And that's just a rough number, a good rule of thumb. So don't be surprised if after 6 months you do have to go up one more time. Dose is the key. Adderall XR or one of the newer DL isomer meds like Adzenys or Dianaval may work well here too. But the easiest answer would be A. So reviewing the 5 Ds, what molecule? So water is a molecule that we all experience every day, and your experience of water is going to be different if I give you 8 ounces versus 64 ounces. You need to know how much you need. And how I give that water to you is going to matter to you. If I give it with a water fountain versus a garden hose, you're going to have a very different experience of water. The duration of action, how long does it keep you hydrated before you need another drink? And then we need our water daily. And so those are it's just an easy way to think about a different molecule. So we're going to now look at some information on comorbidity. And can somebody please give me a time check? If you would, Ed, let me know kind of where I am in the scheme of things. So comorbidity. Remember that about 50%, and that number is, depending on who you read, is a little higher or a little lower at any one time. But comorbid conditions accumulate with time, and over the lifespan, as many as 75 to 80% of individuals are going to develop comorbid conditions, and those can be on the educational side with learning disabilities or on the psychological side, and we'll see that. So continue to assess for comorbidity over time, especially if you notice that the patient is having problems and going up on the medicine hasn't helped or that sort of thing. So we'll talk about an 8-year-old with trouble falling asleep over 3 months, having meltdowns when told to go to bed unless her parent lies down with her. She's worried about school performance and forgetting assignments, and her teachers report her focus and concentration is worse. She complains a lot of being tired and has frontal headaches after school and seems to be particularly irritable when doing homework or other activities that require focus. So what comorbidity do you think might show up? Which one do you think might be the more likely? Certainly she's having some separation anxiety symptoms, but the thought was that she was having more than that. And so the thought is that she would fall more into the generalized anxiety disorder. So the DSM-5 for generalized anxiety disorder, excessive worry or worrying anxiety more days than not for 6 months about a number of events and activities, that they find it hard to control the worry, and that they have impairment. It affects them. It's affecting their life. And then in addition to the excessive worry, they need to have one. In children, it's only one of these, and in adults, it's 3. And in this instance, she had multiple ones: headaches from muscle tension, sleep trouble, irritability, mind going blank. Very often when patients report, I know it, and then my mind goes blank, the first thing I think is anxiety. Now we'll look at a 15-year-old who has been irritable for some time, and it just seems like he's always irritable. He's snappy with his friends, his parents, even recently with his teachers. He decided to quit soccer. He had previously lived for soccer, but about a month ago he just shut down and said he didn't want to do it. Tired every day and napping most afternoon for a few hours, and after eating dinner he goes back to his room and plays video games. When asked about his grades, he had this to say: feeling worthless, and that it is to be expected that his grades are terrible. And then when asked if he wanted to go fishing with friends, he couldn't decide. He couldn't even think. And so this is a pattern that would suggest which comorbid mood problem. Oh, I've got to give you the slide to answer. All right. So you're on the right track with the mood, with more the depressed mood. Irritability in children can be just as important as being sad. And this patient actually does meet the DSM-5 for major depressive disorder single episode. So the timing and the severity of the symptoms and the number of symptoms would meet the DSM-5 for major depressive disorder single episode. And I think the other 2 answers would be good too. But I wanted to point out that this kid's fairly sick and is going to need help right away. The DSM-5 symptoms of major mood disorder: 5 or more of the following, which include depressed mood and or loss of interest or pleasure for continuous 2 weeks, weight loss or gain, hypersomnia, psychomotor agitation and retardation, fatigue, loss of energy, feeling worthless or guilty, diminished concentration, ability to decide, and frequent thoughts of death or suicide. So that would be major mood disorder. So now we have a 5-year-old who's really into My Little Pony cartoons. She loves the toys, the coloring books, and she plays with those incessantly. She will recount the stories in great detail and become agitated if anybody tries to slow her down on that. She's always been very particular, sensory issues, trouble completing work, not because she's not busy, but because she's busy retracing and erasing all the time, very frustrated and acting out a bit. And what picture is this consistent? What does that look like? And everybody's right on track. You know, I think one of the things that we are realizing over time is that OCD is quite common with ADHD, very common. And there's some neuroimaging studies that are coming out that suggest that the tracks of OCD and ADHD are within the brain or running along the same path. Or as one child and adolescent psychiatrist told me, it's like 2 trains on the same track with ADHD. And so the more you look for it, the more you'll find it. I like the normal child with odd behaviors because we certainly see those and we don't need to make a diagnosis, but this child is having real symptoms of OCD and over just more than just a few things. We didn't comment on their social reciprocity, so I wouldn't make a diagnosis of autism there. Although autistic kids certainly can have OCD functions, as you all know. And they thought to be oppositional and defiant because they are oppositional and defiant, especially when it's time to shift, not being allowed to change plans, and they get very irritated about all that. So the DSM-5 for OCD, obsessions, intrusive or unwanted thoughts. I love that word, intrusive. Persistent thoughts, urges, or images that yield anxiety and distress. And they try to get rid of them and they can't, so they result in compulsions, which are repetitive behaviors or mental acts that are designed to lessen the unwanted thoughts. For OCD, it has to be time-consuming and not related to other things. So comorbidity clues, anxiety, checking behavior, the kid that looks at mom every time you ask her a question, reluctant to talk to you, poor eye contact, limited socially, not because they don't want to have friends, they want to have friends, but they're embarrassed or they're too fearful of putting themselves in a social environment. Separation anxiety, irritability, meltdowns, and trouble getting started. They're fearful. And then OCD, you can see, remember that skin picking, these kids that pick their nails, pick their skin, and twirl and pull out their hair. Trichotillomania and excoriation disorder are OCD diagnoses. And they're very common, and stimulants can make them better or stimulants can make them worse. And then, of course, depression. Depressed kids, it's more a lack of joy and interest in what they want to do. They don't always report being sad or tearful, but they do feel lonely or worthless and guilty, that sort of thing. And when we talk about treating these disorders, really the good news is it doesn't matter. We treat them all the same. We refer them for cognitive behavioral therapy. It's important to point out that cognitive behavioral therapy is like physical therapy. You're going to get outside your comfort zone if you're doing good cognitive behavioral therapy. The therapist is going to push the child to the edge of the comfort zone, give them techniques to cope while they're there, and then try to expand them out of their comfort zone. So whatever the anxiety is, they're going to try to work them through it. And just like a physical therapist working on a post-op shoulder, that is not always going to be comfortable. So we're not talking about counseling and talk therapy here. We're talking about strategies. And then SSRI medications that are FDA approved. Cognitive behavioral therapy could often be considered for first line unless there's significant impairment. But you can't go wrong with recommending cognitive behavioral therapy. But both cognitive behavioral therapy and an FDA approved SSRI for the diagnosis you've given the child, first you have to make the diagnosis so that you know which SSRI to use, because they're not all FDA approved for the same indications. And remember, not everyone will need a medication, but all of them can benefit from CBT. Know what you're treating before you use an SSRI. We want to make a diagnosis according to the DSM-5, and it's fairly easy to look those up these days. They're not all alike, and they're not all approved for the same indications. And start low and go slow. It takes 4 to 6 weeks to see full effect. These are not like stimulants in any way, and so definitely have a safety check after a week or two to be sure that there's no suicidal thinking. Increase the dose at a month is a fine thing to do, but again, watch for side effects developing. Very quick review of the black box warning: 4,500 patients in a meta-analysis, twice as likely, 4%, to have suicidal ideation than patients not on SSRIs, but there were no suicides or suicide attempts. And then other studies have shown significant increase, have not shown increase in suicides. Studies actually show that people who went off their meds or didn't are more likely to commit suicide. Finally, ODD. The best and only evidence-based treatment for ODD is to treat the underlying reason for the oppositional defiant behavior. It's often ADHD, but also OCD and others. OCD, if you have a patient who's very oppositional defiant, ask yourself why. And why is the kid so oppositional defiant? And it's usually because of this punishment-anger cycle. They get into this not being able to do what it is they're supposed to do. That's perceived as being lazy or willfully disobedient, and round we go. And the more punishment leads to more anger, which leads to more disrespect, which leads to more punishment. And you can see how it doesn't take very long until you're in a shouting match. And then very quickly, learning disabilities. Remember, the most common learning disability is dysgraphia, or learning disability in writing. The dysgraphia is a physical thing. They get tired hands, they get crampy hands, they don't want to write because it's uncomfortable, whereas disorder of written expression, or LD in writing, is more, I can't get my thoughts on paper, but my writing itself is okay. Both dyslexia and dyscalculia are commonly associated with ADHD in that order. And if I could recommend one resource to you not to leave this webinar without having it, understood.org is if you want to learn more about learning disabilities, if you want your patients to learn more about learning disabilities, understood.org is the where to go to understand it. So thank you, and I think I went over only 1 minute, and sorry about that, Ed. I think
Great.
We'll turn it over at that point. So thanks for everybody's attention. We'll answer questions on the back end.
Excellent. Thank you so much, Dr. Wiley. I've just learned so much from you listening to these medication talks, and to all of our subject matter experts from the chapters. Many of you are on the call today, so thank you. We're next going to go ahead and move towards our next talk here, which let me get the slide here. Here we go. Okay, so the next topic is ADHD in the new payer environment. And Dennis Quo, who many of you all know from the Arkansas chapter, who is now at Buffalo, but has been a big contributor to the Chapter Quality Network in both asthma and ADHD. He and Suzanne Berman have put together this presentation we think is really just extremely relevant in terms of tying all of this back to the new payer environment, quality improvement initiatives, as well as measures, and how it ties into the future world here, or at least the world as we thought we knew it. We know things are in motion, certainly. So let me go ahead and introduce Dr. Berman. She received her medical degree from the University of Tennessee and completed her pediatric residency at Southern Illinois University. She is co-founder and managing partner of Plateau Pediatrics, which is the first NCQA certified level 3 patient-centered medical home in Tennessee. She serves the AAP in a variety of roles at the national level, including the executive committee of the section on administration and practice management, and as well the Committee for Child Health Financing. Dr. Berman frequently contributes to AAP projects and publications regarding medical home practice transformation, rural health, coding, data mining, and policy making. And she and her husband have 3 sons. Suzanne, you sound like you're a busy woman, and with that, I'm going to go ahead and turn it over to you and say thank you for joining us today.
Okay, thank you. Can you hear me okay?
Yes, thank you.
Okay, so if I get too quiet, just send me a message and I can go from pediatrician voice to mom on side of soccer field voice. So today in my part, first I will say I have nothing to disclose. We're going to talk about what is population health as it pertains to ADHD, particularly from the practicing pediatrician perspective, and then look at alternate and innovative payment models that are being tested. And then finally, how these alternate payment models can actually help support better care, particularly for ADHD, which we're talking about today. So first of all, what is population health? That sounds, kind of like something that only CMS people with bow ties, would talk about, or, population health is something maybe that my 13-year-old son who loves to play computer strategy games would, say, oh, look, Mom, my health population is up to 90 points, and I'd say, okay, that's great, go back and finish your math homework. But simply, without sort of, government fluffy speak or whatever, population health is the global health of a group of people. And it's important for us as clinicians to remember that, because it's not necessarily the patients who are getting care from us today. I remember when I was a resident, we would sort of compete with the other residents on our team. If we sent all our patients home, we won. Because that was, you wanted to get to inpatient 0. Or, here in the clinic, I like to think, okay, if I've seen my last patient and charted my last chart, if I finish my schedule, I'm done. And to some degree, that's true, but population health, you're thinking about all the patients that sort of belong to you or belong to a group, even the ones who aren't in your office today, or maybe even the ones that you haven't seen at all because they're not seeing you or maybe not seeing anybody. And we know that medical care is a pretty small part of determining overall health. Like if we look at this sort of pie chart in terms of asthma, say, okay, yes, we know there is a genetic component to asthma. We learned that a long time ago in medical school. How well you do health-wise has a big, one of the big components of that is, do you have access to competent medical care? Do you see a clinician who knows that inhaled corticosteroids are the mainstay of chronic asthma therapy? But if you look at the sort of pink or salmon-shaped wedge, you actually, your health behavior does affect your health. You actually have to take the inhaled, QR or Flovent or whatever daily or twice a day for it to make an impact on your health. And then the huge purple wedge there, the social determinant of health, it looks like a big purple Pac-Man eating the others, and rightfully so, because you can have your patient be compliant with their inhaled corticosteroids until the cows come home, but if they're sitting in a smoke-filled environment, either because of passive tobacco smoke at home or because the air quality in their community is awful from wildfires or industrial pollution, then it doesn't really matter. So looking at the premises of population management, so first define who your population is. Think about your whole panel, not necessarily the highest utilizers of care. Then you want to think about the drivers of health, and not just, I would also say the relative contributions of different drivers of health, and that helps you sort of prioritize your response to the whole. Then you want to match resources to the appropriate people, because one size doesn't really fit all. When thinking about poverty as a social determinant of health, I think that's pretty much incontrovertible. but some very low-income families do quite well, and then others, maybe really struggle with overcoming the challenges that poverty causes for them. And then obviously proactive improvement of health, prevention. As pediatricians, we were doing prevention before it became sexy, and so when we think about obviously prevention to the degree that it's possible, we probably can't prevent ADHD completely, but there are certainly some things we can do for early intervention and mitigating it. So thinking about how ADHD is an important subpopulation in pretty much every pediatric practice. About a tenth of kids preschool age and older have ADHD. That's in the hundreds or thousands of dollars of just medical expenses per child. And the medical expenses, which is primary care as well as behavioral health care, medication, and then ED use, is only maybe a fifth or 20% of costs. As you know, there is a huge educational expense associated with making sure these children get the educational supports they need. There are also other societal costs like legal and juvenile justice costs that are pretty directly associated with ADHD. Obviously, if you've been watching the news, or even if you haven't, you know that Medicare wants to get increased value from the billions of dollars it spends annually on health care, which is reasonable to want to get value out of what you spend. And so Medicare is trying to move away from the fee-for-service model and start paying primarily for things that change health outcomes, or to say that change health outcomes for the better. And as pediatricians, we can sit back and, laugh at the cardiologists who are weeping in the doctor's lounge about MACRA and MIPS, and we can say, I don't take Medicare, so this is a good time to be a pediatrician. But Medicaid programs typically follow Medicare's guidance either by rule or by example. So value-based payments, at least the intent is to emphasize health and health outcomes and pay for things that improve health or provide other sources of health value. Obviously, in the current fee-for-service model, the way payments are structured is if a little is good, more is a whole lot better, particularly where procedures are concerned. We know that there is value in cognitive work. Obviously, as pediatricians, we know that there's a lot of value in prevention. So in some ways, this aligns very well with our mission as pediatricians. So if we're moving away from fee-for-service, you do a service and no matter what the outcome, you get paid for it, what does payment look like under value-based payment systems? So there's usually several revenue streams going on in parallel that would each support your income and the resources needed to run your practice. The first is capitation, which is sort of a nasty word, or a word that has nasty connotations from the 80s and 90s, and it shouldn't. It's sometimes also called per member per month, or PMPM, which is if you have 500 patients on your panel, you get 500 units of per member per month payment, regardless of health outcomes. That's sort of like your base revenue. Episodes are being paid a fixed amount per acute event. We're going to go into a little more what that means in a few moments. Incentives, obviously, or also called pay for performance, are bonuses for achieving certain metrics, and there's a huge variety of what that could mean. That can mean a metric could be structured to to reward you for a certain improvement from your baseline. It could reward you for an improvement against a benchmark standard. It could reward you for getting into a certain percentile. So it could be, you can be graded on the curve or graded according to an absolute A, B, C, D, F scale. And then shared savings is a kind of payment incentive in which if the total costs of care for your patient panel are less than predicted, you actually get to take home some of the savings that are generated. And clearly the system has to be integrated, otherwise you're robbing Peter to pay Paul with sort of stealing from one bucket to fill the other bucket. So how we currently pay for ADHD, at least on the medical side, obviously, as we've discussed, there's a lot of societal costs that aren't shown here. There's sort of three independent silos. Primary care, which often doesn't talk to what's going on in behavioral health. Behavioral health is by far the biggest circle if we were going to make these circles proportional to the spend. And then medication dispensed is the second biggest bucket, actually. But looking towards the future, at least the future as we see it now in our crystal ball, we've sort of reframed the payment structure for ADHD care to be in the context of global payment, which is the outermost rectangle, and then sort of moving inward on that picture, looking at children with ADHD, and then very specifically children with ADHD in a specific time period. So the next slide drills down a little bit more. How would payment for ADHD care using these different sort of complementary revenue streams, capitation, episodes, pay for performance, and so on, what would that look like in your practice? So obviously, capitation, as we talked about, or per member per month, you would get a baseline payment of money for every child in your practice, even if you've maybe never seen them, but they're still assigned to you. Then there's usually an additional payment, a secondary or supplemental per member per month for each child that is more complex, with the higher payments being obviously to more complex children. And so you immediately realize that if you have 500 kids with ADHD in your practice, but you only know who 200 of them are, you will be missing out on a lot of revenue. But you'll still have to provide care for all 500 of those kids. So it is incumbent on you to develop a registry, and whatever that looks like in your practice, whether it's something really sophisticated with your EMR or a paper log or a spreadsheet or whatever will help you know who's in your panel. You really want to know who your patients are and what conditions they have, and to some degree to what level each of those chronic conditions impairs them. So episodes of care traditionally have been applied to adult metrics for all care bundled into one lump sum for a specific event. So classically in the adult world, this was a hip replacement or an acute MI, and the period for those things is pretty well defined. If it's a hip fracture, it's the day you fall to 90 days after you're discharged from the hospital post-op. So no one questions what day you fractured your hip, right? That's all over the medical record. Or an acute MI, the time you presented to the ER with crushing chest pain, that's a pretty well-defined period. Now, ADHD, if you're talking about bundled care, when did ADHD start? The day the diagnosis was made? No, probably not. Hopefully not, right? Hopefully you're following the DSM guidelines as Dr. Wiley talked about. So chronic care conditions, episodes of care, are going to be a little more squishy. Generally, what evolving payment models have done for Medicaid in the pediatric world is using a defined period of time, usually a year. And that could be a calendar year or another year that's sort of set by the program. So obviously, incentives, pay for performance. By and large, most pay for performance measures in, and not just in Medicaid programs, but for commercial insurance, P4P, where children, pediatric metrics are concerned, are almost always HEDIS-based. So sometimes there's some tweaking of the HEDIS measures, but basically these are the mainstay of how pediatric quality measurements are constructed. The upside to that is that at least they're pretty well defined and they're tweaked every year, and that's sort of a matter of, there's not a lot of proprietary definitions going on behind the scenes. HEDIS is actually pretty transparent. The downside, as with many things, child health quality is not studied as rigorously as adult health quality in many arenas. So with the ADHD HEDIS measure, there's usually sort of two halves to it. One is sort of an initial phase, and the other is a follow-up phase. The initial phase, HEDIS defines as, of kids you start on medication, how many did you see again within 30 days for a short interval recheck? And in this case, definitions matter because what are they calling ADHD medicine? Certainly we think of stimulants or maybe Strattera, but is clonidine, is that an ADHD medicine? Or is it a blood pressure medicine? Or guanfacine or something like that? And seen again within 30 days, does a telephone call count? Or does it have to be an office visit? And does it have to be an ADHD office visit? Or maybe could you do a well child check and then say, hey, how's the medicine going? So the devil really is in the detail. The second sort of arm of the most commonly used HEDIS measure to determine the quality of ADHD care you provide is whether the medication is maintained, whether there are pharmacy fills for the medication for an additional 7 months after the initiation phase, and or did you see them in follow-up within the next 9 months at least 2 additional times. And so you can imagine cases where you start medicine and the family doesn't like it and then they stop it, or let's say they move away, or they even get different health insurance and they're no longer, you're no longer sending claims to the same place. All of those things might affect your score. So the revenue that you get from pay for performance, hopefully you're going to use to reinvest in registry tracking and other sort of infrastructure things. Total cost of care, I think that's pretty obvious. In the interest of time, I'm going to skip a couple of these slides. Obviously, different states are doing different things. There are probably, you could pretty fairly say that there are different sort of medico-political culture dishes going on across the country. Arkansas and also Tennessee have used the episode of care model for a year, and also patient-centered medical home using a HEDIS-like metric. They've shortened the interval so that there's a question of if your patient takes a drug holiday for the summer and they have a 90-day gap in filling their medications at the pharmacy, that appears to the Excel spreadsheet that's actually a new prescription when it's not. You're just renewing an existing plan of care. I'll skip this a little bit. This is sort of what New York State has done which is a combination of community-based care and, again, using the HEDIS guidelines for pay-for-performance. Obviously, some payment models are more feasible than others. Here, the vertical axis is a more bundly kind of pay-for-performance system, and the horizontal axis is a more organized system. You cannot make things more bundly unless you also make your payment or your delivery model more organized, which makes sense. So in general, for providing good care for ADHD in your practice under a new or alternate payment model, you want to know who your patients are and then know who your patients with ADHD. You want to staff them appropriately, obviously, using the team-based model and everyone working at the top of their license. To whatever degree you can use your support staff and care coordinators to reach out to the school, to call the pharmacy to see when the last fill dates were, using databases that are available to you to track prescriptions. And then certainly using quality improvement cycles to improve your care as you sort of continue tweaking your care model. So I think that's over time, but I'll stop there.
Great. Thank you so much, Suzanne. Sorry to cut you off a little bit, but we're getting close to the half hour here. Thank you so much. I think that's a good starting point for people to really begin to consider the payment option. Let's move quickly forward here so that we can make sure to get you off. So we're going to move into kind of looking at what we've accomplished over the last several months, gosh, the last year. So here's the big picture. And actually, I'm going to make it a little bit bigger than this. There were 6 chapters that you can see here that were involved in the Chapter Quality Network, with 61 practices enrolled and 192 clinicians. Suzanne or someone needs to go back on mute, which is star 6. And then 137 other staff enrolled, and it included about 4,800. So now this group of chapters is now part of a larger chapter quality network, and we now have 13 chapters that have gone through and participated in one or more CQN projects. I'm going to pause here for a second. Can someone go on mute that's not muted?
And are you 828 number or 931 number?
I'm 828 number.
Okay.
You going to try to mute everyone else?
Yeah, I just had 2 unmuted, and I didn't want to mute you, so we should be okay. Thank you.
Okay, great, thanks. So really, you all are part of a bigger network that's been at it since 2010, and it's just really exciting to see how this learning network has grown over time. So let's look at this particular project, what we're calling the patient picture. So on average, 25 patients were added to MeHealth by each provider, and a total of 22 assessments were initiated per provider across all the assessments. When we look at some of the surveys that you all responded to, as compared to before I began this project, I am seeing, you can see here that we have about 35% of those who answered the clinician survey were not seeing more as a result of the project. Excuse me, let me say that again. There were 62% that had the same number of ADHD patients than they did before the project. And then you can see that 25% are really seeing more ADHD patients as a result of this project. We know in particular that for New York 1, was that New York 2, close to the urban and Queens and Long Island, that this was one of the major focuses for your group, was to become more comfortable as primary care physicians. So we're assuming that some came out of that chapter, but I think it's great to see the number of increased number of patients at the primary care level. You're familiar with these run charts. I'm not going to go over them with you in great detail, but if you look at the first several months months where we were around 57, 59, 52% really is our baseline. And if you remove the summer months, we've really held steady in terms of the Vanderbilt assessment. And we know that this has been a struggle throughout this project, was getting the initial Vanderbilts back. So we're not surprised. But I think it's also important to put in perspective from Dr. Epstein's research, which we shared with you, which was that in their study of primary care, that they were really averaging around 20% of parents using ADHD, at the beginning of their study. So I think that, we're really showing that you all have been really developing good practices around ADHD and of course, the challenge is to continue that good work. We started high and it ended extremely high in terms of Vanderbilt assessments completed within 30 days of medication management initiation, and we're particularly pleased with the last push in September. And what this shows is that you all continue to do testing and have some success around getting those Vanderbilts back. The average total symptom score, which is measuring the average percentage reduction in the score as rated by parent and teacher between the initial assessment and follow-up assessment. And, it's remained in the yellow zone. We anticipate that over the next couple of months, this is going to continue we're going to start seeing more symptom scores improving as you're bringing patients in that are in the 4 and the 6 month follow-ups where you've really been able to titrate the meds and begin to address the comorbidities. We had a lot of engagement, and really this slide doesn't at all really tell the whole story. We had 6 parent advisors to assist us in developing materials and resources and key messages for the clinic visits. We worked a lot of you all worked on behavioral therapy resources available in your particular practice catchment area. The focus on the ADHD booklet and the 504 comparisons. I know we've got Christine Burkall on our call today from Texas Parent Advisor, who was very instrumental in helping us develop some of these materials. And you heard directly from the parents at the learning sessions. As well with this first 2 bullets, you can see that the number of assessments that were completed as a proxy for engagement. Here's your responses to the provider survey. 77% reported that they're getting back more parent assessments as compared to before the project, and 66% are reporting that they're getting back more teachers' assessments. So although we weren't seeing as much increase on our run charts, you all are really seeing improvement happening. And, just a sidebar here is we think that one of the things that we've heard you all say has been most critical, and that speaks to what Dr. Berman just brought up about people working at the top of their profession, is having your MAs or nurse or someone who's dedicated to following the registry, monitoring and following up, in particular around the Vanderbilt scales, makes a big difference in getting those assessments back. So this next slide is around sustainability. And by that we mean from the PDSA testing that you've been doing, have you been going from little testing, if you think about that ramp slide that we showed you over and over again with those little PDSA cycles going up the ramp, we're looking to move from left to right, and that is what has happened. We have a lot of change fully implemented across the practice as you look at these 4 interventions on the left-hand column. We asked you recently about your confidence in diagnosis and med management. It's a lot of our content for our learning sessions, including the one today. 70% of physicians feel more confident in diagnosing ADHD as a result of this collaborative. And 83% feel more confident managing ADHD medications. So I think this whole idea about diagnosing and managing, which was such a critical component of our key drivers and our interventions, and we're hearing from you saying that this collaborative made a difference. So we're very excited about that, and just a big thank you to our subject matter experts in each of our chapters, and to Jay Wiley and Jeff Epstein from our national team. Okay, where do we go from here? So, no surprise here. We want you to continue to focusing on standardizing, delegating, and building reliable systems. And these are slides that we've mentioned to you on the last call. Continue to have your QI team meet. Continue to do testing. Continue to build your standing protocol, your standing orders and protocols so that you've got hardwired, especially with staff and clinical turnover, you've got your systems documented, your workflows are updated. I'm not going to go over this, but again, these are, just reinforcing what we've been talking about all along, and here's our PDSA ramp. And again, moving towards wide-scale tests of change as you move into changing your registry, from those of you moving away from the Me Health registry. You're going to have to do some thinking around, how you're going to make sure to sustain your gains while you're changing your knowledge repository, your registry. Distributing the roles across the practice. We spent a lot of time in learning session 3 with the Share the Care worksheet. And for many of you all, you said, wow, it's really the first time I've really thought about how to distribute the work more effectively. And this is really the beginning of team-based care for those of you who were trying some of this differently this go round. This is just a reminder of the NHS Sustainability Modeling Guide. We went over that on last month's call, but that's a great resource for you all to continue to think about where you need to work. Okay, so nuts and bolts. What many of you all are interested in are the MSC requirements. Just a reminder that 2016 cycle ends, and you must have everything in by November 30th. And of course, Thanksgiving is next week, so you really need to be thinking about this now in terms of getting the information and the attestation completed, and then January 31st for processing credits in 2017. As always, evaluations are extremely important. We look at every one of them, we look at every comment, and we make changes. And we hope that you've seen that we've modeled continuous improvement over the last year as we've tried to embark on presenting and packaging these key interventions for you. Over the past year, it has just been great working with you all, and we've learned so much from you. We hope you've learned a lot from each other, and you all are all experts in ADHD now, and we hope you'll be out there spreading the word of your good work in your AAP chapters and in other domains. So please keep an eye out for emails regarding MOC and the CME credits, as well as the evaluation that will come through ReadyTalk. And then finally, we just want to give a huge thank you to the chapter leaders who worked just so amazingly hard this past year to put out the learning sessions together, to run the monthly calls that were very robust calls with a lot of contribution from the practices themselves, and of course, thank you to each and every one of you on the call for embarking on this Chapter Quality Network journey with us. And with that, we are at 29 after. Oh my gosh, I'm 30 seconds ahead. A big thank you to all of you all. And I think with that, Ed, anything else before we close it out?
No, thank you. I would just point out that I put a link to the evaluation in the chat box so you can access it there. If you are the one that registered, you'll receive a follow-up email that will also have the link for the evaluation. But if you didn't register and you're sitting with someone else, you're not going to get an email. So make sure you get the link if you didn't register for yourself.
All right. With that, thank you, everyone, and have a great rest of the week and Thanksgiving holiday.
Thanks, everyone.